Welcome back to the Radon Smart Review GI Cancer series. We're really excited today to jump into, a really crucial topic in GI radon work. We're building right on what we talked about last time. And this session is really designed for you, our residents, at all levels, whether you're just starting or prepping for boards.
That's exactly right. We're picking up right where we left off, going even deeper into rectal cancer management. Last time, you'll remember, we laid out the basics, the clinical landscape.
Mm.
We really stressed how vital MRI is for staging,
Like, that's critically important.
And we spent a good bit of time on the huge impact of TME, total mesorectal excision, how getting that high-quality TME just plummeted local recurrence rates, a real game changer for surgery, making sure that resection is clean, oncologically sound.
Absolutely. And today, we tackle the next logical question, maybe even a more interesting one. How do we build on that? How can we make things even better than that excellent surgical standard? We're going to dive into the core principles of neoadjuvant radiation therapy. And to do that, we'll really dissect the landmark trials, the ones that answered the two sort of most fundamental questions for us. First, when should we give radiation? Before surgery, after surgery? And second, how should we give it? Long course, short course? These are really the absolute building blocks for every treatment decision you'll make in locally advanced rectal cancer. Understanding them inside and out is just essential for your practice.
Definitely. And to help anchor our conversation today and really make these concepts stick for you, we're going to use a classic case, a standard risk rectal cancer patient. We'll keep coming back to this patient as we go through the evidence. So let's get started.
Okay, let's set the stage. We need an illustrative case, one that really frames these foundational questions perfectly. So imagine a 65-year-old man. He walks into your clinic. He's just been diagnosed with a clinical T3N1 adenocarcinoma, and it's in the mid-rectum.
Okay, T3N1, right away your mind should be going locally advanced.
Okay, now just a quick refresher for our residents on what that actually means. The T in T3, that's about the tumor size and how deep it's gone. T3 means it's grown through the muscle layer of the bowel wall, out into the surrounding fatty tissue, the mesorectum. It hasn't invaded nearby organs yet, that would be T4, but it's definitely outside the rectal wall itself. And the N1, that tells us there's nodal involvement. Cancer cells have spread to 1 to 3 nearby lymph nodes. So this combination, T3N1, it signals a pretty significant risk. Risk of it coming back locally, right there in the pelvis, and also risk of it spreading elsewhere. Needs more than just surgery alone.
That's the key takeaway. Now, critically, his staging MRI, and remember how important MRI is from our last session, shows a clear circumferential resection margin. The CRM, this is a crucial detail. Why? Because the MRI, with its amazing soft tissue detail, lets us see exactly where the tumor is relative to that mesorectal fascia.
Right, that's the surgeon's target margin, the ink for the TME.
Precisely. So a clear CRM on that pretreatment MRI suggests the surgeon should be able to get it all out, achieve a complete resection, an R0 resection, with a nice rim of healthy tissue around the tumor. And we're told he's also a good surgical candidate. He's fit enough for the operation.
Okay, so this whole picture, T3N1, but clear CRM, good surgical candidate, it immediately brings up those core questions about neoadjuvant therapy for us, doesn't it? Even though it looks like the surgeon could take it out cleanly, that T3N1 status just screams high risk. So how does that MRI picture, the T3N1 plus the clear CRM, how does that influence our initial thinking? What's the immediate thought process for you as a radiation oncologist seeing this case?
Well, that clear CRM is definitely good news for the surgeon, confirms resectability. But the T3N1 status, that's the overriding factor here. It absolutely tells us this is locally advanced disease. And for locally advanced disease, we know that additional therapy before surgery and neoadjuvant therapy is highly beneficial. It's pretty much standard of care now. Without that upfront boost from radiation and maybe chemotherapy, his risk of the cancer coming back in the pelvis or even spreading distantly would be significantly higher, even if the surgeon gets clear margins initially. So this patient's situation perfectly frames our first most fundamental question. Do we send him right to the OR or do we treat him first?
Right. And that leads us directly into that first foundational question, the one that honestly changed everything in how we manage locally advanced rectal cancer, the timing. Is it better to give this patient chemoradiation before his TME surgery or after? For a long time, there was a real debate. Different centers did different things. Postoperative treatment was common. But the definitive answer, the study that just shifted the entire paradigm globally, was the landmark German rectal cancer study. Sauer and colleagues published back in 2004. This wasn't just a minor tweak, it was a revolution in thinking.
Oh, absolutely. A massive undertaking. And just so instrumental in setting our current standards. The German rectal cancer study randomized over 800 patients. 800. And these are patients with T3 to 4 cancers or node-positive rectal cancer. So exactly the locally advanced group our case patient falls into. They randomized them to one of two arms, either preoperative chemoradiation or postoperative chemoradiation. And both groups got 5-FU chemotherapy alongside their radiation, standard radiosensitizer. So the design was clean. It directly...
Huge. For you residents, understand what that means in real terms? Fewer patients having the cancer come back in the pelvis. Fewer patients dealing with the horrible symptoms that can cause the pain, the bleeding, the obstruction. It fundamentally changes their long-term outlook and quality of life.
And it wasn't just about recurrence. The toxicity profile was just so much better with the preoperative approach. Giving radiation before surgery turned out to be significantly less toxic. And if you think about it, it makes perfect biological sense, right? When you treat preoperatively, you're targeting a tumor that's, well, smaller, hasn't been messed with surgically, it's in its natural place. The surrounding tissues are healthy, undisturbed, the blood supply is intact, so the tumor and the normal tissues around it are better oxygenated. This makes radiation more effective against the cancer and actually reduces damage to nearby healthy organs like the small bowel or the bladder.
That's a great point. I sometimes use an analogy. Think of it like pruning a tree. It's way easier and safer to prune a small, healthy sapling that's kind of growing on its own, right? You can target the branches you want cleanly.
Right.
Trying to reshape a big, sprawling, mature tree that's already grown into everything around it, roots intertwined, branches everywhere, that's much harder. And that's kind of like treating after surgery. After surgery, tissues are swollen, maybe scarred, displaced, the anatomy is distorted. Treating the tumor before all that surgical manipulation, when it's more contained, less disrupted, the radiation beam can hit the target more cleanly and spare those vital surrounding structures more effectively. Less collateral damage.
And the data from the German trial strongly back that up. Acute grade 3 or higher toxicity, it plummeted. From a really staggering 40% in the postoperative arm down to a much more manageable 27%.
And let's be clear, for residents, grade 3 or higher toxicity, this isn't just a little nausea or fatigue. Grade 3 means severe side effects. Things that interfere with daily life often need medical intervention, maybe even hospitalization. Grade 4 is life-threatening.
Exactly. So reducing that severe acute toxicity from 40% down to 27%, that's a massive improvement in what patients go through right after treatment. And maybe even more importantly for long-term quality of life, chronic grade 3 or 4 toxicity, the long-lasting problems, that was nearly halved.
Huge.
Yeah. Fewer patients dealing with persistent bowel issues, bladder problems, sexual dysfunction, things that can really impact them for years and years.
And maybe the most impactful finding for patients, the one that really hits home when you talk to them, was the incredible effect on avoiding a permanent colostomy. Preoperative therapy doubled the chance of sphincter preservation.
Doubled it.
Think about that. For patients whose tumors were very low down, close to the anus, initially thought to require an APR, an abdominoperineal resection, which for residents means removing the whole rectum and anus, resulting in a permanent stoma bag for life.
Right.
For those patients, the rate of actually being able to save the sphincter jumped from just 19% in the post-op group up to 39% in the pre-op group. That is absolutely life-changing. Maintaining normal bowel function, body image. It's about dignity, function. It's huge.
So the bottom line here, for you residents studying for boards, getting ready for practice, while the German trial showed no difference in overall survival, patients lived just as long on average whichever way they got the treatment. The massive improvements in local control, the dramatically reduced toxicity, and the huge boost in sphincter preservation. Undeniable. The German rectal cancer study firmly established preoperative chemoradiation as the superior approach. It's the standard of care for patients like our case study with locally advanced rectal cancer. This one trial really reshaped global practice.
Okay, so the German trial gives us a definitive answer on when. Before surgery, crystal clear. So with that settled, the next logical question became how. How exactly should we deliver this preoperative radiation? And this led to a really interesting kind of transatlantic debate between two main strategies. Both have good rationales, different advantages, and you'll definitely encounter both in practice.
That's right. The first one, probably the one most familiar to residents here in the U.S., is long-course chemoradiation, LCRT. This is the standard American approach. Typically, it's 50.4 gray, delivered in 28 fractions. So daily treatments, Monday to Friday, for about 5.5 weeks. And crucially, this longer radiation course is given with concurrent chemotherapy, usually oral capecitabine or sometimes intravenous 5-FU. The idea here is that sustained, prolonged exposure to radiation, plus the chemo acting as a radiosensitizer, gives you maximal tumor shrinkage, maximal downstaging, and maybe hit some microscopic distant disease too.
Okay, that's long course. The other approach, very popular in Europe, is short course radiotherapy, SCRT.
Yep.
This is a much more condensed schedule. It's 25 gray, but delivered in just 5 fractions, usually done over a single week, 5 consecutive days. And the key difference here, SCRT is typically given without concurrent chemotherapy. It relies solely on the high dose per fraction, that intense burst of radiation each day, to kill the tumor cells. The biological idea is a high biological effective dose delivered very quickly. Intense, compact.
Exactly, and multiple trials have directly compared these two head-to-head, and what they show is, well, it's a clear trade-off, but maybe a bit nuanced. The Polish one trial, published back in 2006, was a really key comparison. LCRT versus SCRT for resectable rectal cancer, and the results were fascinating, for many people pretty surprising at the time.
They really were, especially when you look at the tumor response. The difference was stark. Long-course chemo-RT, the LCRT arm, it produced a pathologic complete response, a PCR rate of 16%. Just to remind everyone, PCR means when the surgeon takes the tumor out, the pathologist looks under the microscope and finds 0 viable cancer cells left. Complete eradication. 16% with LCRT.
Yep.
Now, compare that to short-course RT, the SCRT arm, the PCR rate there, less than 1%.
Wow, huge difference.
A massive difference in pathological response. So naturally, you'd think, okay, 16% PCR versus less than 1%. That has to translate into better long-term outcomes, right?
Yeah.
Better local control, better survival.
That's exactly what everyone expected. But here's the surprise from Polish one. Despite that huge difference in PCR, there was no statistically significant difference in the long-term outcomes they measured. No difference in overall survival. No difference in disease-free survival. And no difference in local control between the two arms.
Really counterintuitive, wasn't it?
Totally. It basically suggested that for many patients in that trial, even though LCRT shrank the tumor more effectively on a microscopic level, it didn't necessarily lead to better long-term clinical results compared to SCRT,
Right.
especially if the surgeon could still perform a good TME and get clear margins anyway. The major difference they did find, short-course RT had significantly less acute toxicity.
Ah, okay.
Yeah, much easier for patients to tolerate in the short term. Less diarrhea, less skin reaction, less fatigue during treatment. So more convenient, less burdensome. Patients could get to surgery maybe a bit faster with fewer immediate side effects.
Okay, but there's always a bit more nuance, isn't there? The TRGO 1.04 trial from Australia, published around the same time, largely echoed those findings. Similar long-term survival, similar local control overall, but it added a really critical piece of information, especially relevant for certain patients. They did a subgroup analysis looking specifically at very low tumors, tumors less than 5 centimeters from the anal verge. Really challenging location.
Right, where the margins are tightest.
Exactly. And in that specific subgroup, they found a concerning local recurrence rate of 13% with short course RT versus 0% local recurrence with long course, the RT, for those very low tumors.
That is a vital clinical pearl. For you residents, take note of this. It strongly suggests that for those really low tumors, where every single millimeter counts for getting a clear margin, for potentially saving the sphincter, that superior downstaging you get with long-course CRT, that higher PCR rate, it might be critically important.
Makes sense.
Yeah, and those tight spots near the sphincter muscles, that extra tumor shrinkage, that better microscopic cleanup, could absolutely be the difference between needing a permanent colostomy and achieving a successful sphincter-sparing surgery with long-term local control. So while SCRT is great for convenience and lower acute toxicity, LCRT seems to offer a real biological advantage for those challenging low rectal cancers.
Okay, so let's bring that back to our standard risk patient. 65-year-old guy, T3N1, but it's mid-rectal. The takeaway for him seems to be that either approach, LCRT or SCRT, is pretty reasonable. Both are supported by good evidence for similar long-term oncologic outcomes in this kind of location.
Right.
Long course offers that better tumor shrinkage, better downstaging, which we now know is especially key for very low or maybe very bulky tumors. Short course, on the other hand, offers much greater convenience, less acute toxicity. Big plus for the patient experience. So for a standard mid-rectal tumor like his, it really becomes a nuanced discussion, doesn't it?
It does. It's about talking with the patient about their priorities, their lifestyle, how far they live from the center, their tolerance for side effects, and also considering the specific tumor characteristics. Is it bulky? Is the CRM technically clear but maybe a bit close in one area? These factors might push you one way or the other. It's personalized medicine.
Okay, so we've covered when before surgery and how long course or short course with their pros and cons. What's the final piece of this foundational puzzle? It's the timing after radiation. How long do we wait before sending the patient to surgery?
Right, another critical timing question. And interestingly, the answer really depends on which radiation course you gave. It highlights how these two regimens have different biological effects over time.
Yeah, this is fascinating because your first instinct might be get it out quickly, but the data suggests patience is often a virtue here. Let's start with short course RT, that intense 5-day burst of radiation. What happens after that?
For SCRT, the Stockholm 3 trial, published 2007, was really key. They randomized patients to either immediate surgery, like within a week after finishing radiation, versus delaying surgery for 4 to 8 weeks.
And what did they find?
Clear benefit to waiting. The delayed surgery group had significantly fewer postoperative complications.
Okay, so safer surgery.
Safer surgery, yeah. Suggests the tissues had time to recover from the acute radiation effects, the inflammation settled down, but maybe even more importantly from an oncology perspective, the delayed group also had a much higher PCR rate.
Interesting. So the tumor kept shrinking even weeks after the radiation stopped.
Exactly. That phenomenon of continued tumor regression. That intense short course seems to kickstart a process that continues for weeks. So waiting after SCRT was definitively better, safer surgery and better tumor kill. Delaying 4-8 weeks became the standard.
Okay, so wait, 4-8 weeks after short course. What about after the longer regimen, long course CRT, that 5.5-week course with chemo? Do we wait even longer then?
That's what people wondered. The GRECCAR6 trial, published more recently in 2016, looked at this specifically. They took patients who finished LCRT and randomized them to wait either 7 weeks for surgery or wait longer, 11 weeks.
So 7 versus 11 weeks, what happened?
Here, the result was actually the opposite of Stockholm 3. Waiting longer, out to 11 weeks, didn't help. In fact, it seemed slightly detrimental. It actually increased surgical morbidity, more complications during or after the operation for the patients who waited longer.
Really? Why would that be?
The thought is maybe increased tissue fibrosis. Scarring sets in if you wait too long after that prolonged chemoradiation, making the surgery technically harder for the surgeon, potentially leading to more complications. And importantly, waiting those extra 4 weeks, from 7 to 11, did not improve the PCR rate. Didn't improve local control or survival either. No added oncologic benefit, just potentially harder surgery.
So the synthesis here, for you residents trying to piece this together, there seems to be a sweet spot for surgery timing after neoadjuvant radiation. You want to wait long enough to get maximal tumor regression and let the acute inflammation die down.
Right.
But not so long that excessive fibrosis makes the surgery more difficult and risky.
Yeah. Exactly. So the takeaway is, after short course RT, delaying surgery for 4 to 8 weeks is beneficial. That's the sweet spot. After long course CRT, the ideal interval seems to be around 6 to 10 weeks. Pushing beyond 10 weeks likely doesn't add benefit and might, as GRECCAR6 suggested, increase surgical morbidity.
Critical information for planning and for counseling patients about the timeline, and requires close coordination with your surgical colleagues.
Absolutely essential. All right, let's move into some clinical pearls. These are your concise, high-yield takeaways, things to really lock in these foundational concepts, absolutely critical for practice and definitely for your oral boards.
Okay, pearl number 1, the German rectal cancer study. It just fundamentally changed everything for locally advanced rectal cancer. It proved definitively that giving radiation before surgery is superior. Superior for local control and significantly less toxic, both acutely and chronically. And to help you remember the key advantages from that German trial, think LTS.
LTS.
Local control is better, toxicity is less, and sphincter preservation is increased, LTS. That mnemonic really sums up why we switched to neoadjuvant therapy. Nail that, and you can explain the rationale clearly.
Excellent. Okay, pearl number 2. Choosing the neoadjuvant regimen itself, LCRT versus SCRT, involves a trade-off. You need to understand this trade-off. Short course RT, SCRT, its big advantages are convenience radiation done in 1 week and significantly less acute toxicity. Makes it a really good choice for many standard risk patients, maybe older patients, or when convenience is key. However, long course CRT provides superior tumor downstaging. It gets those much higher PCR rates, and that superior shrinkage can be absolutely critical for those very low tumors where sphincter preservation is on the line, or for really bulky tumors where you need maximum regression to help the surgeon achieve clear margins. So you tailor the choice based on the tumor specifics and the patient's goals.
Right.
And pearl number 3. Timing matters after radiation. It's not just about finishing radiation, it's about optimizing the biological window for surgery. After short course RT, delaying surgery for 4 to 8 weeks is beneficial. It lets the tumor keep shrinking that continued regression, and importantly, it reduces postoperative complications. Safe for surgery. But with long course CRT, don't wait too long. The optimal window seems to be around 6 to 10 weeks. Going much beyond that, as GRECCR6 showed, might actually increase surgical complications due to fibrosis without giving you any extra cancer-killing benefit. So hit that sweet spot. Again, close coordination with surgery is key.
Perfect. Okay, let's bring this all back to our patient. The 65-year-old man, T3N1 midrectal adenocarcinoma. Given everything we've just discussed, the German trial, Polish one, Tiogo, Stockholm, Great Cherry Car, how do we approach his treatment decision? What's your thought process, thinking like a resident seeing this patient? Okay, well, first things first. Based on the German trial, upfront surgery is off the table, no question. He has locally advanced disease. Preoperative therapy is the absolute standard of care for him. That's decision 1, and it's easy.
Right.
Now, the more nuanced decision for him, because he's got that mid-rectal tumor with a clear CRM, it's the choice between LCRT and SCRT. This is where we really need to individualize based on the evidence. Since his tumor is mid-rectal and the MRI suggests a clear path for the surgeon, achieving extreme downstaging for sphincter preservation probably isn't the absolute highest priority, unlike if it were a very low tumor right on the sphincter.
Good point. The anatomical location matters.
Exactly. His anatomy gives us a bit more flexibility here.
Agreed. For a mid-rectal tumor like his, where the main goals are really robust local control and setting up the surgeon for a successful TME rather than needing that maximum possible shrinkage for sphincter saving, either LCRT or SCRT could be considered reasonable, valid approaches. So then it comes down to a discussion. If patient convenience, minimizing acute side effects, getting through radiation quickly are really important to him, maybe he lives far away, has work commitments, or just wants to feel better sooner, then SCRT, followed by that 4 to 8 week wait for surgery, that would be a very strong evidence-based consideration. Finish radiation in a week, let the tumor regress, minimize the hassle and acute toxicity.
Then here's the art of medicine part. If maybe we want the absolute maximal chance of tumor shrinkage, even for a midrectal tumor. Or maybe, despite the MRI report saying clear CRM, the radiologist noted it was a bit close in one spot, or the tumor just looks particularly bulky or angry on the images.
Right, those subtle factors.
Or maybe the patient himself just expresses a preference for the strongest local treatment, and he's prepared to deal with the longer course and the concurrent chemo side effects. Then LCRT, followed by that 6 to 10 week surgical delay, might be the favored approach. It really highlights how you take this high-level trial data and apply it thoughtfully to the individual sitting in front of you. Their disease specifics, their preferences, their context. It's not just a flowchart.
Well said. It's informed, shared decision-making. Maybe we should just briefly touch on the techniques themselves again, just to make sure residents have the specifics clear. The how complements the when and why. So long-course tumor radiation, LCRT, as we said, typically 50.4 gray, that's the total dose, delivered in 28 fractions, usually 1.8 grays per fraction, over about 5.5 weeks. So patients are coming in daily, Monday through Friday, for quite a while. It's a commitment.
And that prolonged course, it's specifically designed that way to allow for the concurrent chemotherapy. Usually, as we mentioned, intravenous 5-FU or the oral version, capecitabine. And that chemo does two things, right? It acts as a radiosensitizer, makes the radiation work better locally on the tumor, but it also gives some systemic treatment, potentially hitting any cancer cells that might have escaped the rectum already, even if we can't see them on scans. Micrometastatic disease. So the goal of LCRT is really maximal local kill through synergy plus some early systemic therapy.
Exactly. Now contrast that with short-course radiotherapy, SCRT, much more condensed, 25 gray total dose, but delivered in just 5 fractions. That means 5 grays per fraction. much higher daily dose.
Big difference from 1.8 gray.
Huge difference. And it's typically completed in 1 week, 5 consecutive treatment days.
Yeah.
In and out quickly. The biological idea here is called hypofractionation. That high daily dose is thought to be potent enough on its own to cause significant rapid tumor cell death without needing the chemotherapy boost during radiation.
So quite different schedules, different biological rationales, different toxicity profiles.
Right.
But the ultimate goal for both in this context is the same. Prepare that tumor for a successful surgical resection. Improve local control, increase the chances of clear margins, maybe enable sphincter preservation. Understanding these technical differences helps you explain things clearly to your patients.
Absolutely. Okay, ready to test your knowledge. Let's do our board blitz. Think of these as quick checks, reinforce these key concepts, get you ready for those board-style questions.
Bring it on. Case 1, 65-year-old man, T3N1 mid-rectal adenocarcinoma. Good surgical candidate. His surgeon is planning an upfront low anterior resection. Based on the German rectal cancer study, what do you advise? A, postoperative chemoradiation is superior for overall survival. B, preoperative chemoradiation is superior for local control and has less toxicity. C, the timing of radiation does not matter. D, he does not need radiation if he has a TME.
Okay, pretty straightforward based on our discussion. The answer has to be B. The German rectal cancer study was definitive. Preoperative is better than postoperative for local control and toxicity. Remember, LTS overall survival was similar, so A is wrong. Timing clearly matters, so C is wrong. And T3N1 disease definitely needs radiation, even with TME, so D is wrong. Preoperative is the standard.
Perfect. Case 2. According to the Polish 1 trial comparing preoperative short-course RT to long-course chemo-RT, which of the following statements is true? A, short-course RT resulted in superior local control. B, long-course chemo-RT resulted in superior overall survival. C, long-course chemo-RT had a significantly higher rate of pathologic complete response. B, both arms had similar rates of acute toxicity.
Okay, thinking back to Polish 1. Local control and overall survival were similar, so A and B are out. Acute toxicity was lower with short course, so D is wrong. The big difference was PCR. Long-course chemo-RT had that much higher PCR rate, around 16% versus less than 1%. So the correct answer is C.
Exactly right. That high PCR rate is the key distinguishing feature of LCRT in that trial. Okay, final one. Case 3. A 58-year-old woman has a T3N0 rectal cancer, but this one is located low down, 4 centimeters from the anal verge. The surgeon is worried about getting a negative margin and wants to preserve the sphincter if possible. Which neoadjuvant approach offers the highest chance of tumor downstaging to achieve these goals? A, short course RT followed by surgery in 1 week. B, short course RT followed by surgery in 6 weeks. C, long course chemoradiation with capecitabine. D, upfront surgery with intraoperative radiation therapy.
Okay, key phrase here is highest chance of tumor downstaging, especially for a low tumor where sphincter preservation is a major goal. We know SCRT gives very low PCR rates, so A and B are less likely to provide maximal downstaging, even if B has the correct timing post-SCRT upfront surgery. D is wrong for T3 disease anyway based on the German trial. That leaves C, long-course chemoradiation. We know from Polish 1 and the TRG subgroup analysis that LCRT gives significantly higher PCR rates and better downstaging. So when maximal tumor shrinkage is the priority, especially for a low tumor like this, LCRT is the preferred approach. Answer is C.
Excellent reasoning. That hits all the key points. So we've really laid down the essential foundation today, haven't we? TME importance, the why and when of preoperative radiation from the German trial, the how LCRT versus SCRT trade-offs, and the timing nuances for surgery. This is the bedrock knowledge. But as always in oncology, the field doesn't stand still, does it? It keeps evolving.
Absolutely not. These foundational trials, they answered critical questions, but they also paved the way for the next set of questions, especially around how to best integrate systemic therapy. We touched on concurrent chemo with LCRT, but the real hot topic now, the natural evolution, is the concept of total neoadjuvant therapy.
TNT?
Right, TNT, you hear about it everywhere now. It's a huge area of discussion, ongoing trials. It's definitely the next frontier. Can you briefly explain the core idea of TNT for our residents?
Sure. Basically, TNT takes the neoadjuvant concept a step further. Instead of potentially giving some chemo concurrently and maybe some more after surgery, adjuvant chemo, TNT aims to deliver all the planned treatment, both the full course of radiation and the full course of systemic chemotherapy before the patient ever goes to surgery.
So consolidating everything up front. Exactly. The idea, the hope, is that by hitting the cancer hard locally with radiation and systemically with full-dose chemo earlier, you maximize the chances of tumor response, maybe get even higher PCR rates, and crucially improve long-term outcomes by tackling that micrometastatic disease much earlier and more effectively, potentially improving disease-free and overall survival, not just local control.
It's a significant shift from the paradigms we focused on today, where chemo might be split before and after or only given concurrently.
It is. And it opens up other possibilities too, like potentially watching some patients with a complete response very closely and maybe even deferring surgery altogether, organ preservation, but that's a whole other topic.
For sure. But TNT is definitely the next major evolution, building directly on the foundations we've discussed, something everyone needs to be aware of. Okay, let's try to recap the absolute key takeaways from today's session. Really cement this foundational knowledge. First, remember, TME surgery was a huge advance, drastically cut local recurrence. But neoadjuvant therapy was needed to optimize things further. And remember, our mnemonic for the German trial's proof of preoperative superiority, LTS.
LTS.
Local control is better, toxicity is less, sphincter preservation is increased, pre-op wins.
Second key takeaway, building on that. The German rectal cancer study proved giving radiation before surgery is superior to giving it after. Better local control, less toxicity, acute and chronic, and significantly higher rates of sphincter preservation. Changed everything.
Third, when you're choosing the neoadjuvant regimen, LCRT versus SCRT, understand the trade-off. Short course offers convenience and less acute toxicity. Great option for many standard risk patients. Long-term survival seems similar for many, but long-course CRT gives much better tumor downstaging, higher PCR rates. This can be absolutely critical for those challenging low tumors or bulky tumors needing maximum shrinkage. It's about picking the right tool for the job.
And finally, fourth takeaway. Timing to surgery matters, and it depends on the radiation regimen. After short-course RT, wait 4 to 8 weeks. This allows for continued tumor regression and leads to safer surgery with fewer complications. After long-course CRT, aim for surgery around 6 to 10 weeks. Waiting much longer doesn't seem to improve cancer outcomes and might increase surgical difficulty and morbidity. Find that sweet spot.
Excellent summary. We really hope this comprehensive session has armed you with the critical insights into neoadjuvant management of rectal cancer. This is truly foundational knowledge for every radiation oncology resident.
Absolutely. This really sets the stage perfectly for understanding the more advanced concepts that are now standard practice or under investigation, like total neoadjuvant therapy, TNT. And that's exactly where we'll be heading in our next session. Rectal Cancer Part 3. We'll dive into TNT, the trials, the different ways to sequence chemo and radiation up front, and the exciting data emerging there.
Looking forward to that. For complete practice oral boards, questions based on today's material, and for detailed show notes, please visit radoncsmartlearn.com. And make sure you subscribe to RadOnc Smart Review so you don't miss Part 3 and our future sessions. Thanks so much for tuning in.